Today's PowerPoint is an introduction to the process of diagnosis for counselors. Last week we talked a little bit about some of the objections or reservations that counseling students tend to have about using the DSM, and we talked about how the DSM is a book that counselors use to diagnose different mental illnesses and mental disorders. So this week, as we dig a little bit deeper into the process of creating and making a diagnosis and learning to flex your clinical judgment muscles, I wanted to invite you all to struggle with it. And that phrase, an invitation to struggle, comes from Mary Pfeiffer, who is someone who has done a lot of work with counseling and therapeutic relationships and published some well-known popular books in our field, including Reviving Ophelia, which was specifically about counseling adolescent girls, very popular in the 1990s. But definitely Mary Pfeiffer being a very wise clinician, and I find that that phrase, an invitation to struggle, is one that is a useful phrase to keep in mind as you learn about diagnosing mental disorders as a counselor. So we know that the behaviors that we are likely to see in our clients or hear our clients describe or hear those that love our clients describe are that are associated with a mental disorder. Those are the behaviors that cause distress, that cause dysfunction, cause impairment in day-to-day functioning. There are certainly behaviors that are annoying or quirky or unusual, but the definition of a functional human behavior is very, very wide, and it's not meant to capture all of the quirks or idiosyncratic behaviors that such a diverse population of people is likely to display. But if it is a behavior that is associated with a mental disorder, then it's causing some kind of problems in a person's day-to-day functioning. When you are talking to your clients, though, you do want to cast a wide net. So you want to look very broadly at how a particular behavior is manifesting itself in a person's life, and you want to ask a lot of questions around that behavior. So you want to keep in mind that the definition of functional human behavior is very, very widely defined, very broad. At the same time, when you are going out fishing for symptoms, when you're going out looking for symptoms in your client so that you can make a formal diagnosis and you're doing that assessment process, you do want to cast a very wide net so that you are getting those behaviors or potential behaviors that might be associated with a disorder in the broad context of your client's life. Some red flags that you always want to be on the lookout for would be those related to cognitive functioning, such as memory, being able to connect a thought, string together coherent thoughts, different medical conditions that a client might be experiencing. Sometimes the medical diseases might create symptoms that are very similar to those associated with mental disorders, and so you need to try to differentiate between the two. And then anytime your client is using substances in their life, you want to do a very thorough assessment. Consider that a red flag, something that could get in the way of you being able to make a clean diagnosis if you don't gather enough information about that. And then you always want to be on the lookout for potential for psychosis. And psychosis would be seeing, when basically boils down to when clients are seeing or hearing things that aren't really there, and or experiencing a large or experiencing a lot of paranoia. Your plan to be very good at diagnosis is to be familiar with the entire gamut of mental disorders, so all of the DSM-5, but you also really want to think about developing mastery of the sections of the DSM that are most common to your site. If you are in private practice, with the general population of working adults who are coming in to get services, you really want to know the mood disorders, the obsessive compulsive disorders, the anxiety disorders. You really want to know those really, really well. You also need to be very familiar with substance use disorders. But if you're in a different type of treatment facility, if you're in an inpatient setting, hospitalized setting, then there might be other disorders like eating disorders or psychotic disorders that you want to be much more familiar with. If you're working in a nursing home or with an elderly population, you need to really be very clear about the cognitive disorders. And that's not to say that those disorders that I have just provided as examples don't show up in lots of different settings, but you really want to work towards developing mastery of the sections of the DSM that are most common to your site. The purpose of a diagnosis is to help counselors to be able to determine what type of treatment a client should have. And the diagnosis should also indicate the prognosis. How is this all going to turn out for the client? If a diagnosis does not do those things, then it's probably a bad diagnosis, and you need to revisit what you have come up with and look to see if maybe you are over-pathologizing or under-pathologizing something. When using the DSM-5 system for diagnostic procedures, you're going to be looking for the primary diagnosis, and the primary diagnosis would be the most acute condition that requires the most intensive skilled services. Now, in past versions of the DSM, there was what was called a multi-axis system, where there was an axis 1, an axis 2, axis 3, and axis 4, and then disorders were placed on each of those axes. What ended up happening is that disorders that were on axis 1 or axis 2 were always seen as the primary diagnosis. And axis 2, which included the personality disorders, had kind of its own reputation and own descriptor of somebody who had symptoms appearing on axis 2. What the DSM-5 tries to do by getting away from using that axis 1, axis 2, axis 3 is to whatever that primary diagnosis is, that gets listed first in the clinical record. So it could be something that in a previous version of the DSM would not have come up until axis 4, but under using the DSM-5 model of diagnosis now, that primary diagnosis is listed first so that it gets the attention that it deserves. V codes are something that are used to help describe psychosocial and environmental factors. You can see the list here of all of the different types of things that might not be a disorder unto themselves, but they are all definitely factors that can influence how a disorder plays out by exacerbating symptoms and making things a little bit more complicated, and definitely very important factors for counselors to keep in mind when they are determining the prognosis and trying to make a decision about treatment planning. Your diagnosis includes not only just the mental disorder's name, the title of the diagnosis, but also provides some information about how severe and how disabling the diagnosis is. So adding specifiers and additional criteria to the diagnosis can provide information about how that diagnosis is going to impact the client's life. I want to talk a little bit about the DSM and the ICD. So these are both manuals that are used in the field. The ICD, we'll start with on the right here, is a listing of all medical conditions that are used in psychiatric treatment and medical treatment. These are where the codes come from that counselors use when they are billing or documenting something in a chart. These are codes that are usually 3 digits, then a period, and then 2 more digits. And this manual was created by the World Health Organization. And the purpose of it really is more epidemiology related. We talked about last week how being able to do a thorough assessment is important for your clinical work, but it's also important in helping us as a society to be able to address mental health issues by tracking them properly. So when you look at the purpose of the ICD, then you think about that a big purpose of it is to track and identify patterns in mental disorders across the global population. There is online a free copy of the ICD classification of mental and behavioral disorders. This is a a portion of the ICD or a supplement to the ICD that is more focused on how a counselor would use it rather than just for the epidemiology tracking type purposes. So you can go online and just put this into Google search bar and download a PDF file. That would be your free copy of the ICD. Most agencies, private practices, and other clinical settings are using the DSM-5 for making diagnoses. And so again, the DSM-5 uses the ICD for its codes. And so the coding system in the ICD is incorporated into the DSM, but the DSM provides something that is much more oriented to how a mental health practitioner would be using it in practice, as opposed to the epidemiology tracking and counting of mental disorders globally. So the DSM does incorporate a developmental approach to psychiatric disorders. That was seen as a big improvement over time in how the DSM has evolved. And when you look at these numbers, the DSM-5 and the ICD-10, those are the number of editions that these manuals have gone through. The DSM-5 also was updated to look at how the same symptom might occur across multiple disorders to help practitioners to be able to differentiate when seeing a symptom that is present among several disorders. Also provides a severity rating, incorporates genetic and neurobiological findings, but of course it is not without its criticism. Some people have said that that there are poor reliability levels in the diagnoses, that there was flawed methodology, and that some of the new disorders that were added lack empirical evidence. Another big criticism that we talked a little bit about last week related to bereavement is that there have been some reduced thresholds for diagnosis, meaning that the diagnosis is quote unquote weakened, and so more people would meet that criteria to be classified as having a disorder. Here's an example from a presentation that I attended that was done by ACA in 2013 with Jason King and Matt Buckley, and this is a sample DSM-5 diagnosis. You'll see that the primary diagnosis is the first listed here, but others are listed as well. These numbers, the V code, and then the 301.89, those are the ICD codes, and then these would, on the right of the codes, would be from the DSM. You see that there is a HUDAS score. This is an assessment that we talked about last week that could be incorporated to give clinicians an idea of the severity of the symptoms as they are at the time of presentation that the diagnosis is formulated. Now, thinking about diagnosis and going back and reviewing a little bit about assessment that we talked about last week, you remember now we're going to kind of tie those things together, assessment and diagnosis. So assessment is formal or informal, it's ongoing, and we're gathering information related to the nature of the problem, the severity of the problem, impact of the problem on the client's life, and specific or possible treatment options. The mental status exam is something that you will cover in your other classes. You should cover that in counseling skills and techniques and also in your assessment course. But the mental status exam is very useful, especially when psychotic features might be present, when a person is not oriented to time and place, seems kind of out of touch or confused. Doing assessment means you have to know how to ask good questions, and this is a great list to get you started. If you want to pause and make sure that you can read through all of these good questions that will be useful to you when you're doing clinical interviews and intakes. When you do ask questions, make sure that you're clear about your intention of asking the question. Are you asking the question to get the client to think? Or are you asking the client a question because you need a specific piece of information related to your ability to make a diagnosis? Remember to always ask questions one at a time. Always assess for safety and try to avoid following up your questions with a piece of advice. Here's a few cautions that sometimes people fall into when they are doing an intake interview that you can read through. And we'll close with just reminding everyone to attend to the influence of culture when doing assessment and diagnosis.